The physical examination showed posterolateral rotatory drawer test is positive. Starting from the anterior compartment, there were many signs for the lateral ligamentous pathologicity and their intra-articular associated findings. Capsular tear at radiocapitellar joint level, chondropathy of lateral aspect of capitellum, chondral damage of anterosuperior of radial head, loose collar sign, and radial neck was seen beyond the cartilaginous portion of head. Radial head subluxed posteriorly on capitellum with the hypersupination. There was also synovitis. Next, put a suture anchor at the supinator crest and the lateral epicondyle. After suture anchor was applied at the supinator crest through the mini skin incision, we proceeded to arthroscopy in posterior compartment. Performing a forceful supination, there were widening of ulnohumeral gap and drive-through sign was positive. And next, lateral epicondyle was prepared for applying the 1.8 mm soft suture anchor double load. The graft was prepared. High 5 number 2 was sutured midway of the graft, then fold once. The sutures became the leading suture. Next, create a tunnel from the supinator crest to the joint, then retrieve a passing suture loop from the posterolateral portal out to the mini incision. Then retrieve the passing suture and the full strands. Then pass the leading suture and the graft via the passing loop from the ulnar footprint into the joint and then out through the posterolateral portal. Each pair of the suture from anchor was passed through the graft using needle and then tied a knot and then cut the suture. Next, pull the other two ends of the suture to slide the graft back into the joint and then tie a knot. While tying, make sure to pull the leading suture with small tension so the graft is not twisted while tying. Then cut the sutures. Next, prepare bone area for the knotless anchor to fix the leading suture posterosuperiorly. While applying the anchor, make sure assistant pull the distal stump with certain tension to prevent the graft from slipping proximally while tensioning the leading suture at the anchor. Next, each distal stump of the graft is fixed at the supinator crest for LUCL reconstruction and at annular ligament for RCL reconstruction. On LUCL reconstruction, use the suture from the anchor to wrap around and tie over the tendon graft. On RCL reconstruction, high 5 number 20, pierce through annular ligament twice, then wrap around and tie the other tendon stump. For both LUCL and RCL reconstructions, while the surgeon ties the suture around the tendon, the assistant should pull the tendon distally while maintaining the elbow in 60 degrees of flexion and neutral position, ensuring there is no varus alignment. Both tendon stumps are then sutured with another anchor for backup fixation. Additional RCL reconstruction can tighten the annular ligament complex, which will improve the PLRI. Also, please notice that the tendon is tied in a compression fashion by tying suture stump from different pairs. Then tie the other sides of suture stumps to press down the tendon onto the bone, and then suture the tendon once to prevent any possible slip. Lastly, looking through the arthroscopy, the widening of ulnohumeral gap disappeared.